Hello everyone, I am Dr. Karthika Kannan, Professor of Oral Medicine and Radiology, currently employed as Principal and Head of the Department, Adibara Shakti Dental College and Hospital, Chennai. In this video, I have made a small presentation about oral candidiasis, a review. The most common fungal infection that occurs in the oral cavity is candidiasis. It is also called as candidosis, moniliasis, and popularly known as oral thrush. This infection is caused by candida, which is a dimorphic fungi. That means it occurs in both yeast and hyphal form. Candidiasis is a mucosal and cutaneous condition caused with a common etiological agent from the Candida genus of fungi. It is a commensal that is present in the oral cavity, and in a normal healthy individual, its count ranges between 200 to 500 cells per milliliter of saliva. Candida is an opportunistic infectious agent that, being a battery of proteases, is poorly equipped to invade and destroy the tissue unless it is provided with an opportunity to rapidly reproduce and a portal of entry. It is an endogenous infection, which means the infection occurs from within. Almost 80 to 90% of oral candidiasis is caused by the species Candida albicans. The other members of Candida genus includes Candida tropicalis, pseudotropicalis, cruzi, parapsilosis, guillermondi, glabrata, and stellatodia. The oral candidiasis can be classified. Candidiasis can be classified into intraoral and extraoral candidiasis. Intraoral candidiasis is again subdivided into acute type, chronic type, and candida associated lesion. In the acute type, we have the pseudomembranous type, which is popularly known as oral thrush, and the erythematous type. Earlier it was called as atrophic or antibiotic sore mouth. And in chronic types, again, pseudomembranous, erythematous, hyperplastic, otherwise called as plaque-like, and nodular types are included. Under the title of Candida-associated lesion, we have three entities. One is angular cheilitis, another one is dengue-stomatitis, third one is median rhomboid glossitis. Under extraoral candidiasis, we have mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, gastrointestinal candidiasis, orificial or intratriginous candidiasis, and the last one is systemic candidiasis. In this presentation, I will be concentrating only on oral candidiasis. Candidiasis is a common infection among infants, pregnant women, and old age. It can be attributed to the developing immune system in the infants and the gradual weakening of immune system in old age. If an young, healthy individual is having oral candidiasis, we should look for the predisposing factors. Predisposing factors are broadly classified into local factors and systemic factors. The local factors include poor oral hygiene, smoking, prosthesis or appliances, xerostomia or dry mouth, excessive use of mouthwash, keratotic white lesions, and topical steroids. So these are the local factors you should look for when you find oral candidiasis in otherwise healthy individuals. Among the systemic factors, we have age, broad spectrum antibiotic usage, corticosteroids, cancer therapy, cancer chemotherapy, and immunodeficiency condition that can be congenital or acquired. Some of the acquired immunodeficiency conditions are diabetes mellitus, HIV, leukemia, and lymphoma. So, if you find candidiasis in a young healthy adult, we should look for both, or you should investigate for the presence of local or systemic factors. First, let me discuss about the most common type of oral candidiasis, pseudomembrane candidiasis, which is otherwise called as oral thrush. It is characterized by the presence of yellowish white, patchy or plaques or flecks, which resembles cottage cheese appearance or curdled milk appearance. So these white spots or white layer or a white pseudomembrane can be easily removed by scraping that area with a piece of cotton or gauze. While removing the white patch, it leaves an red erythematous raw area which may bleed. Okay, and the white plaque or flecks contains candidal hyphae, yeast, desquamated epithelial cells, and food debris. Put together, they form the pseudomembrane or flecks. The common site for the occurrence of pseudomembranous candidiasis are less self-cleansing areas that are present in the mouth. The retromolar area, the vault of the palate, and the floor of the mouth. These are the area which are less self-cleansing. So let me show you some cases where you find the flecks, white flecks of oral candidiasis. Here you can appreciate there are numerous white flecks that may resemble the food debris or curdled milk or cottage cheese appearance and it is predominantly located in the retromolar areas. And in this case, we can see there are white flecks that are present in the vault of the palate. So some of the patients who are asthmatic will be using inhaler that may contain bronchodilator in addition to corticosteroid. So in such patients, when the jet of the spray which contains the steroid hit the junction of the hard and soft palate regularly, and after usage, if the patient is not washing the mouth properly, the continuous contact of steroid over the localized area of the palate results in depletion of local immunity in that particular area, making that area vulnerable for candidal infection. Okay. The next type I am going to discuss is erythematous type, formerly known as atrophic type of candidiasis, popularly known as antibiotic sore mouth. Why it is called as antibiotic sore mouth? Because it often occurs in patients who are taking broad spectrum antibiotic for a long time. When a patient takes broad spectrum antibiotic for a long time, it suppresses the bacterial colony in the oral cavity, thereby giving more abundance of food for the fungal to grow easily and produce an infection. And most commonly, it occurs in the tongue and it manifests as an area of loss of papilla. Such lesions, when it presents on the dorsum of the tongue, it is in constant touch with the palate, which may result in the transmission of infection from the tongue to the palate. Here is a classical case of kissing lesion of the oral candidiasis, where the patient is having an erythematous candidiasis in the dorsum of the tongue and a similar lesion in the vault of the patient, because the dorsum of the tongue and the vault of the patient is in constant touch. So the infection may spread from the dorsum to the palate. And because of this transmission, it is called as kissing lesion of oral candidiasis. The next type of candidiasis that we are going to discuss is hyperplastic candidiasis, popularly known as candidal leukoplakia. In contrast to the pseudomembranous candidiasis, Hyperplastic candidiasis is a non-scrapable lesion and it clinically may resemble a leukoplakia. So that is why the term candidal leukoplakia, even though it is an infection caused by candidal organism, its clinical characters mimic like leukoplakia. That is why it is called as candidal leukoplakia. It is a firm white leathery plaque that cannot be removed by scraping. And how we can diagnose this condition is if we take a biopsy and in the histopathological examination, we often find that the candidal hyphae has infiltrated into the deeper layer of epithelium. In my introduction, I would have told you, Candida, despite being a battery of proteases, is poorly equipped to invade and destroy. So, in all other types of candidiasis, we can find candidal hyphae or yeast only in the superficial layer of the epithelium. Only in hyperplastic candidiasis, we see deep infiltration of candidal hyphae into the deeper layer of epithelium. Also, if we treat such lesions with antifungal therapy, the lesion may resolve. So these are the two indication or evidences to confirm our diagnosis that it is a hyperplastic candidiasis and not any other keratotic white lesion. This is another classical case where you can see a diffuse area of white patch which is non-scrapable, which was also extending into the gingiva and the alveolar mucosa, almost resembling like proliferative verrucous leukoplakia. But for our surprise, it responded very well to the topical candidiasis and the majority of the lesions disappeared. Now, after discussing the most common types of oral candidiasis like pseudomembranous, erythematous, and hyperplastic candidiasis, now let us discuss the lesions which are grouped under the title called as Candida-associated lesions. Okay, the first one is danger stomatitis. So, danger stomatitis is a type of candidiasis where you can appreciate erythematous change below that danger bearing area. Okay, and manifests as a diffuse inflammation restricted to the danger bearing area. It is very often seen in the maxilla when compared to the mandible. The reason being there is a close adaptation of maxillary danger with that of the maxilla, and the saliva is being pushed away so that the protective effect of the saliva is not there under the danger bearing area, and also the food accumulation makes that area vulnerable for the fungal growth and infection. Based on the Newton's classification, depending upon the area of involvement, danger stomatitis has been staged as stage 1, stage 2, and stage 3. If there are numerous palatal petechiae, under the danger bearing area, it is the stage 1. If there is a diffuse area of erythema, either covering the entire area or the majority of the danger bearing area, it is the stage 2 type of danger stomatitis. Here you can see a patient who is wearing a metal cast partial danger, and corresponding to the metal cast partial danger, the area shows a diffuse erythema. So another classical type of danger stomatitis. It not only comes under the acrylic danger, it can also occur under metal cast partial dangers. And in the stage 3, under the danger bearing area, you see multiple hyperplastic mucosal proliferation, which is called as palatal papillomatosis. Such changes can be also seen in non-danger wearer patient also, especially patients who are having high palatal vault and heavy smoking habit may show lesions resembling to the palatal papillomatosis under the danger. Here is another classical case where you can see there is a diffuse erythema covering the entire danger bearing area with papillomatous proliferation in the palate, a classical case of palatal papillomatosis. And in such cases, if you want to prove the presence of candidiasis, it is always a good idea to take the scrapings from the danger base and not from the palate. If you take a scraping to prove the presence of candida by doing a culture, it is better to take it from the denture base, not from the palate. The next lesion that we are going to discuss is angular cheilitis. Angular cheilitis is characterized by cracking, fissuring, and scaling at the lip commissure. Angular cheilitis can be caused by various reasons like nutritional deficiency, B complex deficiency, iron deficiency, and anemia, as well as decreased vertical dimension of the denture, which makes there is a fold at the angle of the mouth, and moisture in the form of saliva get accumulated there, and it predisposes for infection by the fungus, that is the candida. And also some of the children used to get angular cheilitis because of the bacterial infection from the nose caused by Staphylo and Streptococci. Okay. So the difficulty for the patient will be difficulty to open the mouth, bleeding from the commissure, and severe pain. These are the symptoms complained by the patient who are having angular cheilitis. So it is multifactorial. We need to find out the exact cause. Okay. And if it is by the fungus, if it is by the candida, it will respond very well to the antifungal treatment. The third lesion that we are going to discuss under the candida associated lesion is median rhomboid glossitis. Look at the term. It occurs in the middle of the tongue, and its shape is rhomboid, and it is also called as glossitis to denote the loss of papillae that is present there. So it occurs in the midline, its shape is rhomboid, and there is loss of papillae resembling inflammation, that is glossitis. So its site is very peculiar. It occurs almost towards the posterior region of anterior two-thirds of the tongue, and majority of the time it is asymptomatic, and some of the patients may show hyperplastic nodules and fissures. Hyperplastic nodules and fissures. This is the circumvallate papilla. Don't confuse it with median rhomboid glossitis, which is present here. These are the row of circumvallate papilla that is present at the junction of anterior two-thirds and posterior one-third of the tongue. Okay, whereas this region is the median rhomboid glossitis with nodular change and nodules with the fissure change. So earlier it was thought to be a developmental abnormality because of the failure of tuberculum impar to recede before the closure of two lateral lingual swelling. But based on the Koch postulate, we are able to isolate regularly the infecting organism, that is the candida, from this lesion. So that is why it is grouped under candida associated lesion. Now, if you want, majority of the cases, oral candidiasis, the diagnosis is straightforward and it is based on the clinical findings. But if you want to prove in laboratory the presence of candida, we can go for cytology. We do a scraping and we make a smear and stained by KOH or PAS, periodic acid shift stain, where you will be able to see the background desquamated epithelial cells, and you can see the filamentous hyphae, and you can also see the small dots there. They are the yeast form. That is why candida is called as dimorphic fungi. You will be able to see the hyphal form that appears as filaments, and you will be also able to identify the yeast form which appears like a dot. And this is the appearance of silvery pearly white colonies of candida in sabrods, dextrosugar media. And we can also take biopsy in the case of hyperplastic candidiasis, where you can see the filamentous hyphal form invading deep into the layers of the epithelium. That is the evidence for to prove that there is a candidal invasion deep into the layers of the epithelium, suggestive of hyperplastic candidiasis. And regarding the treatment, we have topical treatment of antifungal agent, and we can go for systemic treatment in severe cases. So the topical includes suspension, clotrimazole is available, nystatin is available, ketoconazole cream is available, nystatin ointment is available. And regarding systemic, The first drug of choice for oral candidiasis or oropharyngeal candidiasis is fluconazole. In the beginning, they may give 200 milligram, followed by a maintenance dose of 100 milligram or even 50 milligram based upon the severity of the condition. And the treatment has to be given for a very long period of 2 weeks, almost 15 days have to be given for complete eradication of candidal infection. We have other alternatives like ketoconazole, which have few side effects, and itraconazole is a relatively newer drug, which is also tried in severe cases of oral candidiasis. So here I present a case where you can see an erythematous candidiasis in the dorsum of the tongue, which has been treated with candid mouth paint, and after almost 10 days, the lesion shows sign of regression and healing. So definitely the treatment is effective and can be tried. So with this, I have come to the end of my presentation. I just want to emphasize the words of Sir William Osler. He who studies medicine without books sails in an uncharted sea. But he who studies medicine without patient does not go to sea at all. So learning oral medicine is 50% is from the book, but rest 100% is from the patient. So the more you see, more you learn. Thank you for watching my video. Thank you, everyone. Thank you.